I see people coming in, but I'm gonna get it started. Welcome, my name is Veronica, and I am the Buffalo CoLab Manager and Senior Training Assistant. Thank you for joining us today. Today is the second of this three-part series of public workshops on opioids in the workplace. The beginning of the creation of this series began in 2019, when even before the pandemic, our partners in Buffalo recognized the growing prevalence of opioids in our community and their increasing impact in workplaces. Fortunately, we saw the pandemic exacerbate these issues with increasing devastation they are causing to individual lives, families, and communities. However, the role of workplaces in the opioids epidemic have been largely ignored. Whether through workplace exposures or injuries, work has been a significant contributor to waves of opioid epidemic. So Western New York Council of Occupational Safety and Health, ECMC Clinic on Occupational and Environmental Medicine, and the Cornell ILR Buffalo CoLab joined together to offer this series of workshops to community members locally and nationally, resources, data, and information, and tools to help. Today is the second of a three-part series. The first workshop was on February 2nd, sharing the extent of the opioid epidemic and why opioids are a workplace issue. Today, our conversation will be about three topics. First, opioids and workers' compensation, where we will hear from Dr. Singh, a physical, medical, and rehabilitation physician at ECMC. Next, we will hear from Dr. Sonnenstuhl, Associate Professor Emeritus in the Department of Organizational Behavior, Cornell ILR School, about workplace policies on prescription drug use. The last part of our conversation will be on opioids and mental health concern, where we will hear from Carl Shallowhorn, a mental health advocate and consultant. The final workshop is a free Narcan training on overdose recognition tips, Narcan administration, and access to Narcan kits. It will be held in person here in Buffalo on Thursday, March 2nd at 10 a.m. to noon at UAW Local 9 at 35 George Carl Boulevard in Williamsville, New York. We will be sending a follow-up email with the first workshop and today's recording, as well as a registration link for the in-person training. Before I pass it off to Dr. Singh, I just want to note that this webinar is being recorded and will be sent out to attendees afterwards. There is a Q&A option at the bottom of the Zoom panel where you can ask questions throughout Dr. Singh's presentation, and the remainder of the questions for the remainder of the presenters will be presented for response at the end of the session today. We'll hear from folks and have formal Q&A at the end. I will be regularly monitoring the chat questions. Feel free to enable your closed captioning at this time. Again, we will be sending out the recording resources and information afterwards. So without further ado, I'm going to pass this to Dr. Singh.
Ronnie?
Yes.
I think Dr. Singh was going to go on at 10:45, and I was going to.
Oh, you're first, Will?
No.
Well, I'm passing it off to you then, Will.
Okay.
Okay.
That's fine. I'll stay out till 10:45. Thank you.
Okay. So let me share my screen with everyone. Okay. I'm a professor emeritus at the ILR school, and in addition to being an emeritus in the Department of Organizational Behavior, I've been studying alcohol and drugs for 50 years in the workplace. And the one thing that I want to emphasize today is that there are not any simple answers to the workplace and dealing with alcohol and drugs. There's a lot of work that's involved here, and I'm going to give you a framework of what has worked historically in addressing alcohol and drug issues in the workplace. I'm going to give you a brief overview of medication treatment for opioids, which is a really important part of it, but not all of it. I'm going to highlight some programs that work and have worked incredibly well throughout history in terms of dealing with programs. And then I'm going to talk about creating a workplace community partnership to address opioids in Buffalo. Fortunately, Buffalo has already got all of the resources to make a successful program. First, I want to highlight something that Cheryl said in our last meeting, which is the stigma that's involved around alcohol and drug use in American culture. Alcoholics and addicts are the American folk devil that we all know about, that we should not become. The attachment here is that because the American culture values self-control so highly, addicts and alcoholics historically have been seen as out of control, unable to control their behavior. And primarily we've dealt with them by shunning them and punishing them. But we've also had some varied programs with varied success throughout history to treat alcoholics and addicts. So the primary barrier to treating alcohol and drugs in society and in the workplace is the stigma that's attached to them. And I can tell you from a long experience in the workplace that most work organizations would like to see the alcoholic or addict go away. And there's been a lot of resistance to working with them and treating them because there's a perception that they lack willpower and that they didn't use these drugs and alcohol responsibly. So that sets up the kind of dynamic of shame that alcoholics and addicts experience, and Cheryl talked about that last time, I thought quite nicely. And we really do need to overcome that. So one of the first things you need to know about successful programming is that if you don't have a policy that's affirmative about working with and treating alcoholics and addicted individuals, you've really got no program. Basically, the default is we don't want you here. And this policy is very short-sighted because we can actually address these addictions and return people to the workplace and be successful in terms of work and family and community generally. Now, I want to just mention briefly about medication and the use of opioids. And there's a wonderful report by the National Academy of Sciences that came out in 2019, which talks about medicated treatment. And there are a couple of things I want to highlight here. And Dr. Singh, I'm sure, is going to talk about medication in much more depth. But one of the things they emphasize is that medication is not a quick fix. And effective treatment programs need to have access to medication to treat opioid use disorders. Currently, methadone, buprenorphine, and naltrexone are all approved by FDA to treat opioid use disorders, and they recommend that these medications be available to everyone, and not everyone is suitable for every one of these things. My impression is that Suboxone now is kind of the standard that is actually used. What you need to know is that in terms of job performance, and the workplace is always concerned about job performance, whether it's management or labor, is that when you are dealing with opioids, it's when the individual is going to withdrawal and having all kinds of negative experiences, the job performance is most likely to be impacted. Medication treatment allows people to return to performing normally. It blocks all of the withdrawal symptoms and lessens the likelihood that somebody's going to re-engage with the drug. And some workers may be on medication for a short term. Others may be on medication for a much longer period of time. So these medications need to be prescribed by somebody who's a competent medical practitioner who's trained in addiction medications, and it can be managed in that way. Now, the important thing to also understand in terms of thinking about the workplace is that this is not a quick fix. People with opioid use disorders come with a whole host of other issues involved as well. So if you are going to treat these issues, you have to be aware of co-occurring conditions that people have and treat them as well. And most importantly, as we heard from Cheryl last time, people come with all kinds of mental health disorders that they need help for. They have substance use disorders that they need help for. They have chronic pain that they may need help for. And if they've been using a needle injection, they may even have HIV problems. So there's a lot of other things that need to occur that the workplace needs to provide in terms of caring for and treating the person with an opioid use disorder. And there's some really significant barriers that we need to think about in terms of making medication available. First of all, there are just too few practitioners that are actually trained in addiction medicine. So one of the big pushes is to increase the number of people available. There's also constraints on where that can be done. Here in central New York, we have one clinic basically that does this kind of work that serves all of central New York. And it's really stretched at the moment. And another problem is our fragmented healthcare system. There's just not enough communication between doctors, the psychotherapist, the whole panoply of groups that need to be of help. And one of the big problems is that this medication can be prescribed, but not all insurance plans pay for them. And we need to make sure that it is readily available. So let me provide you with a quick overview of some of the things in the workplace that have been used to address alcohol and other and opioid problems. And I want to emphasize that we've been at the workplace dealing with alcohol problems for a long time. This individual, Benjamin Rush, you may recognize from colonial history, a signer of the Declaration and Treasurer of the United States, and also the father of American psychiatry. He's also the person who came up with the idea of the disease of inebriety, which becomes very important for how we think about alcohol problems all through the 19th century. He did some of the first experiments with alcohol in farming, because we were an agricultural community, and discovered, lo and behold, that when you served workers light beverages, you had more crops, cleaner fields. When you fed them rum, you got poorer results. In any case, his basic treatise is the Inquiry into the Effects of Ardent Spirits upon the Human Body and Mind, which is published in 1785. And that becomes the framework for the American temperance movement throughout the 1800s, and also Prohibition. So during this period, one of the things that was going on in the workplace is that apprenticeship was widespread, and part of the role of the master was to provide beverages for his apprentices. And they stopped providing rum and served beer instead. And in 1830, when they realized that the alcohol and beer was also problematic, they created teetotalism. The other workplace thing that was going on during this period was a complete workplace prohibition, and the railroads were early adopters. Now, what I really want to emphasize during this period is something called the Washingtonian Movement, which a lot of people don't know anything about. And the Washingtonian Movement in the 1840s was the largest movement to address alcohol problems in the United States. It's based in this idea of inebriety, and that the individual needed to give up and abstain from drinking alcohol. And the only way to do that was to help other alcoholics or drunkards at the time to also abstain from drinking. If this sounds like early framework for Alcoholics Anonymous, it is. And I can tell you that when AA was set up, Dr. Bob and Bill Wilson did not know about the Washingtonian Movement. And when they really discovered it in the 1950s, it came as a big revelation. But this is very successful in terms of getting people sober and keeping them sober. It was the largest movement in the country at the time. The other thing that was going on in the first part of the 19th century was state prohibition. And in 1851, Maine passes the first prohibition law, and it created quite a lot of havoc, as you can imagine. And 12 other states adopted these laws, but they were relatively short-lived because after the Civil War, they all went away. Now, what's interesting about the post-Civil War period in addressing alcohol issues is that you have this huge influx of labor as industrial workplaces expand, and drunkenness is a big problem. And again, one of the things that emerges that many of us don't know about in terms of the history of alcohol and drug addiction treatment is that, again, there's a whole group of fraternal organizations that emerge, Good Templars, Good Samaritans. These are all examples of fellowships that come together and support one another in sobriety and keeping people sober. they're a big part of what happens in that 19th century. I want to call your attention to one group in particular. The Red Ribbon Reform Clubs were actually developed by the Women's Christian Temperance Unions. And these were very popular, and they worked very closely with large industries such as lumbering and mining, where they developed these sorts of programs within the workplace. So there's a deep relationship between these kinds of programs and working to keep people effectively sober them up and keep them clean and sober. There's also this great movement during the latter part of the 19th century to do away with alcohol altogether. And all of these groups were active here in New York State. The Anti-Saloon League was particularly active and took a leading role in eventually creating national prohibition. So moving forward from national prohibition in 1920, 1932, 33, we see what is often called the modern alcoholism movement. And there's a shift from focusing on the alcohol to really focusing on the alcoholic as a sick individual that can be helped and treated. And there are three organizations during the 30s, the 40s, the 50s, and the 60s that play key roles here. Alcoholics Anonymous being one, the Yale Center for Alcohol Studies at Yale University, this is now at Rutgers University, and the National Council on Alcoholism. All of these organizations work together to promote the idea that alcoholism is a disease. They promoted workplace alcohol programs in industry, working very closely with both labor and management. And here in New York State, probably the most famous program is Kodak in Rochester with Dr. Norris, who was very, very key in promoting such programs across New York State and around the country, actually. In 1970, we see something else emerge. It's the first time that there's a big federal push to recognize alcohol abuse and alcoholism. And there's a lot of things that are going on with NIAAA when it's set up under the Hughes Act, including making sure that that there's insurance coverage for people with alcohol problems and treatment becomes available. But one of the only program in that legislation that NIAAA is directed to create are occupational alcoholism programs. And this is where employee assistance programs come to the fore with their emphasis on alcohol and other drugs and mental health problems. And these are really important programs at this point. They created core technology where we recognize employees with problems based on job performance. We teach supervisors and stewards how to work with those performance problems using a process called constructive confrontation to motivate employees to get some help, go to a treatment facility and get help and return back to work with the support of their work organization. So this is the core technology. And I will give a shout out to my colleagues, Harrison Trice and Paul Roman. Their book, Spirits and Demons at Work, is a classic and really is a key part of this core technology and continues to be. Now, in the 80s, EAPs actually lost their focus to some extent on alcohol and other drugs and began to focus more on mental health problems. And this is because of the differences in training in terms of mental health and alcoholism specialists and some conflicts about who would control these programs, and the emergence of out-of-house EAP providers that were basically primarily focused on mental health, less focused on alcohol and drugs. And one of the key reasons these out-of-house programs emerged was because work organizations, for the most part, were not doing training. They weren't implementing that core technology with either supervisors or stewards. And most organizations, except for very large ones, such as Ford, UAW, didn't have the medical expertise to actually handle these programs. And I will give a shout out here to the Ford UAW program, which Cheryl mentioned last time. That's a program that originated in the 1970s and has been incredibly successful. And we're very fortunate to have Ford UAW in Buffalo. Opioids has a very different history with work in the United States. First of all, Dr. Rush in his medical practice did use opium, but there was no characterization of opium addicts as bad during this period. And basically, the most common user of opium was actually females who were using more opium. That begins to change in the late part of the 19th century. You get this emergence of the dope fiend who's really addicted to opium. And there's a major push to do away with the Chinese opium dens. There's a great concern that after the Civil War, in which morphine is used with soldiers, they're returning home and they become addicted, and physicians are trying to help them with their morphine needs by providing that. There's also opium in lots of patent medicines, so people are becoming addicted in that process. So there's this whole idea of, again, the opium addict becoming a slave to his addiction and lacking free will. And throughout that part of the 19th century, there's a lot of effort to prohibit opium use at all in the United States. And the Harrison Act in 1914 basically it was an act to regulate opium use as well as some other narcotics. But the Treasury Department and the Supreme Court interpreted the legislation very narrowly as complete prohibition of all non-medical opioid use. In that sense, doctors who are trying to treat the addicts by providing them with small doses of opium to keep them at normal levels so they could actually function, were actually arrested. Over 25,000 doctors were actually arrested on narcotics charges. 3,000 of them were imprisoned, and thousands, literally thousands, lost their medical licenses. So one of the problems in terms of the medical profession, in terms of their work with people with opium and addiction problems, has been this kind of historical cracking down on physicians, and we still see that in terms of how physicians are treated in terms of their work by the government. This creates that black market, reinforces heroin users as problematic, as heroin users are being imprisoned, they're prison, mostly in Lexington and Fort Worth, where they're given some treatment. But the success rates when people leave there are 2 to 7%, and it's not very successful. Methadone becomes a treatment available after the Second World War. Mostly it's used to treat heroin addiction withdrawal. And the idea is that you help people withdraw, they become, during their withdrawal period, stabilize them, and then maybe don't use it at all. But they did discover that you could maintain people actually on relatively high doses and they would be able to resume normal life again. So that sets up the methadone clinics, but there's a lot of controversy around them because, again, of this image that this is a substitution and people aren't really dealing with their addiction. In the 60s, we see, again, a reemergence of concerns about heroin use in particular, partly because we have Vietnam soldiers returning who've gotten addicted during their time overseas. We also see during this period an uptick in college students' use of opium, in heroin. So there's a lot of community concern, and this is when we begin to see programs like Synanon emerge to deal with it. We see methadone maintenance clinics emerge more forcefully, and President Nixon is actually very supportive of the idea of methadone treatment and drug testing at work and in the military. At this point, the work organizations are not very interested in treating methadone treatment or drug testing, and it's primarily in the military that it finds a home. Some of this begins to change in the 80s with the Reagan war on drugs and the crack epidemic, and it's a real push to get drug testing into the workplace. And I remember Attorney General Thornburg at the time saying it was our moral obligation as every workplace to have drug testing in place. And this is where drug testing enters the arena and actually transforms what's going on in the workplace in terms of thinking about alcohol and drugs. Because with drug testing, there's a kind of punitive behavior. So whatever good was being done with the EAPs, where there was good alcohol and drug treatment, there was also a lot of bad things that were happening, because more often than not, when people were identified through drug testing, they were not given treatment, but were excluded in one way or another from the workplace. And this is very unfortunate, but it does lead to another significant thing in the 1980s and 1990s. We see this reemergence again of these fraternal organizations. And I spent a lot of time in the 90s studying these peer-based member assistance programs, particularly in the airlines and the railroads and amongst transit workers. And one of the things that we found is that these peer-based programs that were basically operated by labor organizations were very, very effective in addressing alcohol and drug issues. Let me talk briefly about Operation Redblock, because it's a good example of what was going on during this period. There was a clear focus on alcohol and other drugs. This would include opium and heroin, was part of the issue. And what's important here is that there was a continuing commitment from both the railroads and the brotherhoods to save workers' lives and jobs. There was a lot of education around alcohol and drugs, and learning to use alcohol particularly responsibly. There's a lot of discouragement of using illegal drugs. And there was an agreement by which management allowed the unions to address these problems directly. So there's a peer network that was set up, composed of people in recovery, social drinkers, and non-drinkers that would work with their co-workers that they identified as having a problem, get them into a treatment program where they had access to all kinds of good therapy and treatment. And when they came back to the workplace, they had their job, and there was a loving community, if you will, that was supportive of their sobriety and keeping them sober. So there's a lot of success here, and just point to a few things. One of the most important things is it really changed the whole complexion of the drinking and drugging on the job in the 1990s on the railroads. And it reduced particularly their arbitration cases. They practically went away for alcohol and drug problems, and they saved millions and millions of dollars every year because these arbitration cases around alcohol and drugs were cost them on the order of 10, 12, $15 million a year. And there was an increased commitment from the workers to their union, and there was also improved labor management relationships. Now, another group of programs that developed during the 1970s, and I want to call your attention to, are the professional associations that were implementing alcohol and drug programs. These had a lot of bite to them because one could basically tap into and leverage their license. If you didn't cooperate, get sober, you're gonna lose your license and not be able to practice. One of the really great programs is the Airline Pilots Association. This is founded in 1970, based again in this kind of peer relationship. And in fact, the early program was Birds of a Feather, focusing on the co-pilot and pilot relationship as a way of identifying people and getting them into treatment. Today's program is very successful. It's got extensive education and prevention, a lot of training of pilots and co-pilots to identify problems and get people help when they need it. There's lots of excellent treatment resources, and there's extensive drug testing as part of the treatment and follow-up. And it's such a model program that a few years ago, I was on a panel with a management representative and labor representative, and I came and talked about these sorts of peer programs using the Airline Pilots Association. Turns out that the other two speakers said, gee, I was going to talk about that as well because it's such a great program. But these programs have been phenomenally successful. And again, it points to the kind of fraternal linkage here. It points to the necessity of having good medication available, up to date in terms of the kinds of therapies that people need in a community. Now let me talk a little bit about particularly opioid-focused programs, and there are a lot of these in the examples in the literature, and there are some that we can talk about, and there's some industry programs in construction and fishing that are fairly successful. There's also some company programs, but the key to these programs is that there is medication treatment that is available, and that there's a lot of commitment to returning people to successful employment. So there's lots of psychotherapy and peer support, and there are really good pain management programs that are available to support people. And again, we see that for these programs to be successful, there has to be a big commitment from industry and employers to make them work and to make their work organizations safe. One interesting example that I want to tell you briefly about is Phishing Partnerships in Massachusetts. These are embedded in the fishing communities of New Bedford, Gloucester, and Plymouth and Chatham. This is an industry program. Brandeis University has been studying these programs, but in each of these communities, there's broad employer support with the treatment community and police organizations. And again, they have extensive community education, prevention about opioid use and dependence. So everybody understands that this is an illness that can be treated, and that people can be returned back to normal behavior and have successful lives. Again, there's pain management programs available, and all the captains and all the crews are trained in terms of providing identification, referral, and support. So again, you see this kind of fraternal support that's going on. Treatment is tailored to whatever the individual needs. And there's lots of recovery support and follow-up. So again, this is highlighting some common themes that we see in programs that are actually working successfully in the larger arena. Another program I wanted to call your attention to is the Belden Company. It's also called Pathways to Employment. And Belden had a difficulty in terms of its ability to actually hire employees because they failed drug testing. What's unique about this is that when people fail the drug test, there's a community-wide effort between treatment and the employment and businesses and community college and the healthcare system generally. So you fail a test, they get you into a drug treatment program. And on successful completion of the treatment program, you're offered a job and skills training at the community college, and you're supported in follow-up and support for sobriety. Again, this is an innovative way of thinking about the way we address these problems. Now, there are some keys here that I've already highlighted that I think we need to think about in terms of a comprehensive community partnership. And I'm not going to go through all of them here. I'm going to leave them for you to look at because I've already mentioned most of them here. But what I do want to leave you with is how do communities like Buffalo that already has this nice little partnership going, how do we strengthen those relationships and reach out so that we can support smaller employers and smaller unions, because the programs I've talked about really require an enormous amount of resources. And I think the Buffalo community and hopefully some of the other communities here are able to build on that and create strong partnerships. So with that, I'm going to stop here. And I think we have a few minutes for questions. Ronnie?
There are none.
Hi. So do we have a few questions from people?
I don't see anything in the Q&A.
Okay. Well, I think we're about ready for Dr. Singh to come on. So I am eager to hear his comments
Well, I really think your historical perspective was really enlightening. Unfortunately, I have a feeling that we're probably going to be part of a presentation about 30 years from now with people talking about us. So, well, hopefully in a positive way. Okay, let me bring up my slides. Okay, hopefully everyone can see my slides now.
Mm-hmm.
Okay, So just to introduce myself, my name is Amrit Singh. My specialty is physical medicine and rehabilitation, and I'm also certified in pain management. I've been practicing in New York since 1996 and have been treating injured workers since that time. All of it has been managing their pain symptoms. And during this time, there's been quite a significant pendulum swing in how we manage pain. Several years ago, both at the federal and state level, pain was being touted as the fifth vital sign. There was a time when a physician could be cited for medical malpractice if they did not treat the patient's pain adequately. Now, the pendulum has swung the other way. Now, physicians are being penalized, and it's considered misconduct if you prescribe opioids. So the whole situation has been kind of muddied, and whether the pharmaceutical industry had anything to do with it, that's a topic for another discussion, and it's still ongoing. From my perspective, when I'm in a room with a patient, the relationship is between me and the patient, and I'm trying to help the patient. And my role as a physician is to try and help them. Their injury, if it causes pain, that is part of what I'm going to be helping them with. So that's what my discussion is going to be based on, is essentially what happens when it is a provider-patient relationship and I am trying to treat an injured worker for their pain symptoms. I'd like to start with a couple of examples or stories. These are patients of mine. The first patient I'd like to talk about, RR, he was hurt, worked as a building maintenance worker, had a lifting injury, hurt his back, ended up having back surgery twice, was off work for periods of time. We managed to get him back to work, and he was able to continue working full-time. Now, the only way we could get him fully employed and working full-time was by using an opioid. In his case, we were using a buprenorphine patch, a 5 microgram patch, which is changed every 7 days. And he also took tramadol 50 milligrams up to 3 times a day for breakthrough pain. He was also on gabapentin and Cymbalta, which is duloxetine. It's an antidepressant, both of which are considered adjuvant pain medications and help with the pain in addition to the opioids. Now, this particular individual had a history of gastric bleeds. We couldn't give him ibuprofen or any other non-steroidal anti-inflammatory. So when you have guidelines that say that you got to treat a patient with all these first-line medications and treat them, there are times when you cannot treat the patient. In his case, his pain management was successful, allowed him to work. He worked full-time, retired in May 2021, is getting his full pension, which is now beneficial. He is now off the opioids now. He is, now that he's not working, we have him on a medical marijuana program, and that is what he's taking, and takes Tylenol if needed. But since he's not working, he can manage his pain symptoms without the opioids at this point. The morphine equivalent for his treatment was 24 milligrams. So that is a way of trying to figure out how much more the quantity of pain medication someone is taking, and his worked out to 24 milligrams a day, which is not that high because the workers' compensation guidelines say a maximum of 100 milligrams a day. The next patient, entirely different situation. He was a truck driver, was sleeping in the bunk of his truck when his partner was driving. The driver braked suddenly, the belts failed. He fell from the bunk into this hallway thing that is in between the bunks, had severe injuries, ended up having surgery on his lower back 3 times, the neck 3 times, with the most recent surgery about a year ago. And he's older now, and he had a surgery about a year ago, which unfortunately resulted in complications, and he became temporarily paralyzed from the neck down, had to go to a nursing home. He's gotten better, can walk now, still has difficulty using his hands, but he's back home now and is able to walk. In his case, the pain has been so significant that we have him on a morphine equivalent of 200 milligrams a day, which is double the workers' compensation guidelines. However, In his case, with his situation, we have not been able to get him down below that level of pain medication, and that medication is what allows him to function. He was never able to go back to work, so he has been on disability since the injury. We also have him on gabapentin, trazodone, and baclofen as supplementing his medication. He's another one who cannot take anti-inflammatories because of being diabetic, having kidney problems. Now, here is the problem. We've got two different kinds of pain. One is acute pain, which is pain that happens, you sprain your ankle, you have acute pain. Maybe you take a narcotic for 2 or 3 days, the swelling goes down, your ankle feels better, and you're done. In an injured worker, we often face a situation where the pain persists after the injury itself would have been assumed to have healed and the patient should be better. However, the pain persists either because there is an ongoing problem that is causing the pain to persist. That is what is called non-acute pain or chronic pain. And that is kind of the main focus now of opioid use in work injured patients, because that is a subset of patients that do need ongoing opioid treatment. And that is where providers have a lot of difficulty in managing those patients, pretty much so because of the stigma now that has been attached to opioid use, so much so that physicians are afraid of prescribing the medication, and sometimes the patient and the family are afraid of taking the medication. And you kind of are stuck in the situation where you have incomplete pain relief for the patient. The Workers' Compensation Board came up with guidelines on management of non-acute pain. And in the guidelines, and this is partly from the guidelines and partly my own thoughts on the matter, opioids are useful in a patient where you've tried everything else pretty much. Physical therapy, chiropractic, cognitive behavioral therapy, and pain self-management techniques. These all seem to be, they're good buzzwords, but if you take the example of SS, who's had 6 surgeries in all on his spine, cognitive behavioral therapy and pain self-management has kind of gone by the wayside now. First of all, we have no resources in our community to have enough providers to provide that treatment. We don't have psychologists or counselors. If they exist, they don't want the paperwork of workers' compensation. Hands are tied by case managers. So there is no help. The guidelines have a lot of stuff that is good stuff, but we don't have those facilities available to us, at least not in Western New York to that degree. And if you go into a rural community, it is zero. So you're left with medications essentially as your only way of treating those patients. And then that's a constant struggle with the insurance carrier and other entities that look into prescription opioids. As I mentioned before, opioids would be useful when other medications are contraindicated, as we saw in the patients that I give examples on. One of them has had a gastric bleed. He's actually had abdominal procedures done for the bleed. He can't take any anti-inflammatories. The other gentleman is diabetic and sees a nephrologist for kidney issues. He cannot take anti-inflammatories. Our next option is something like Tylenol. Now that also in excess can cause liver problems. So you are now, the two main things that are non-narcotics are the anti-inflammatories and Tylenol. And there are quite a few patients that cannot take either one of those without having problems. So then you're back at the situation as what else can you give them for the pain? And you're left with an opioid, which has its own issues, but sometimes there is no other option. Sometimes the pain is so severe that an anti-inflammatory and Tylenol is not going to be enough to manage the pain, and you do need an opioid to manage the pain. And as I mentioned, the side effect profile of the medications that other medications that are used, we use anti-seizure medications like gabapentin, we use antidepressants like duloxetine or amitriptyline. They all come with their own set of side effects, and you often have to try and figure out what you can do to help the patient while you're minimizing the side effects. Now, it is not that opioids don't have their own side effects. Opioids have their own side effects. They have constipation, testosterone deficiency, cognitive changes, and the worst one of all is the dependency issue. A patient on opioids is going to become physically dependent on the medication. That is different than an addiction, where there is a more of a psychological component to their need for the medication. The patient, once they are on long duration of opioids and you try and stop it, will have physical problems because of the physical dependency. And again, that is something that has to be considered with the opioids. You have to have a discussion with the patient and make sure that they understand that that may be an issue. As part of that management, we enter into a pain contract with the patient, which means essentially the patient complies with the rules under which the opioids are prescribed. There is no misuse or excessive use of the medication, and they are subject to monitoring, which can include random pill counts to make sure they have not overused or handed their pills over to someone else, urine testing to make sure that the medication that is prescribed to them is actually in their system, and to rule out other illegal substance use. And unfortunately, sometimes you do find things where you prescribe the patient one medication and they actually have something else in the system. That is essentially pretty much a ground for stopping narcotic prescription at that point, because there's obviously more of a secondary issue there going on, and those patients are then referred into some kind of a rehabilitation program for the drug dependency, which again, as I mentioned before, is hard to find. And then to try and get it covered under workers' compensation is yet another hurdle to face. So yes, the guidelines are very nice. The spoken words and the written words from the board are also very nice to hear. But when it comes into practice, the insurance carriers are always a roadblock, and it comes down to money, and they will not pay for the patient to be treated. The other things that the workers' compensation guidelines require us to look at is something called a pain assessment and documentation tool. This is something that's done at each visit and is a tool to assess whether the medication is actually helping the patient. So essentially documents whether it's helping them in the activities of daily living and what degree percentage reduction they have in pain, and whether it is causing any side effects, and whether the side effects are tolerable or intolerable, and whether anything needs to be done to manage the side effects. That particular tool is something that the board requires in order to justify ongoing prescriptions of opioid medications. However, because a lot of the input in that tool is a subjective report by the patient, we again have the hurdle of a case manager and a peer reviewer saying, well, how can you prove that this medication is actually helping the patient? Because it's a subjective measure, we try and document, well, the patient can get up out of bed, can get to the bathroom, go to the bathroom, can toilet themselves independently, they can make themselves a meal, they can eat, they can dress, they can bathe. But there is no measure that you can give the board to say that this is the improvement in function. Unfortunately, functional assessments and pain assessments remain subjective. And it is often used as grounds for denial because you can't give the insurance carrier a number to say, look, the patient was at 60 before and now he's at 120 before. That measurement does not exist, unfortunately. We also look for aberrant behaviors, like I mentioned, diversion of medication, overuse of medication, calling for an early prescription. Those are all behaviors that raise a red flag when you're prescribing opioids. We have tried to manage the early prescription issue by making sure that any patient who's an opioid only receives a prescription for 28 days. What that does is if the prescription is written on a Tuesday, it will always come due on a Tuesday. So you avoid all the phone calls on Friday that say, well, I'm going to be running out of medication. Can you give me a script today, even though my prescription isn't due until whenever? Because what that does is just builds up excess medication in the patient's home, which then again increases the risk of abuse and misuse. So again, that forms part of the pain contract as well. And it is an attempt to make sure that our patients stay within the rules of use of the opioid medications. Another thing that the guidelines have recommended is something called a risk tool, which is kind of very similar to an alcoholism assessment tool. It's a few questions that you check off answers on, and you come up with a score, and that pretty much tells you in a way whether the patient is at low risk, moderate risk, or a high risk for being abusive of opioid medications. And the items on there are things like a family history of substance abuse with alcohol, illegal drugs, prescription drugs, a personal history of substance abuse, their age, a history of pre-adolescent sexual abuse and psychological disease. All of those get a score, and you come up with, as I said, low risk, moderate risk, or high risk. Again, these are just tools that are useful to assess the patient when you first prescribed an opioid. But at the end of the day, I think the final thing is the physician-patient relationship and the trust between the two to continue to make sure that things will work the way they intended to. What is very important when we talk to a patient is that set appropriate expectations. The medications are not going to fix their pain and take it away completely. That is impossible. The only way you can have complete pain control, if you're under general anesthesia, you won't feel any pain. But obviously, that is an extreme measure. The patient has to realize that there will still be some pain, and the intent of the pain medication is not to take the pain away completely, but hopefully allow them to function better. Again, at the functional level may be anything like returning to work and being able to function in the workplace without cognitive impairment, which is important if you're in opioids and you're operating machinery that requires a lot of attention and skill, and you are on an opioid that is going to affect your concentration. That is risky and puts you at risk for injury. It is kind of like driving under the influence. So those, again, the workplace and the use of the opioids needs to be measured against each other and make sure that the patient can function. The first patient did building maintenance. The medication did not affect his cognitive function. He was able to function. In his case, the dose was low enough to provide pain relief without causing any impairment of his ability to think, figure out things. It essentially was something that allowed him to physically function at his workplace. The goals for the patient, essentially, we want to make sure that they have appropriate functional goals. Again, because you cannot provide 100% pain relief, the goals need to be realistic. You can't say that, well, you'll have enough pain relief that you can go jogging every day. That may not happen. Maybe you can get enough pain relief that you can use an exercise bicycle for 25 minutes and exercise on that. That may be a reasonable goal. You're not going to be lifting heavy weights. Lighter weights and more repetitions could be done with a more reasonable goal. So again, the patient has to understand that there are going to be limitations of function, no matter what degree of pain medication they're on. And also, the functional goals need to also incorporate the potential risk of further injury. So the fact that your pain is better, but you have issues with failed hardware in your lumbar spine because of surgery that didn't go well, does not mean that you can now start moving furniture around in the house because the pain is better. You may end up injuring yourself more. So again, you have to be realistic in your functional goals. Now, along with the opioids, that is not the sole solution, as I said before. It would be great if we had other disciplines available to us, like counselors to do cognitive retraining and stuff like that. However, we don't have those. The adjuvants we can use is essentially an exercise program, maybe physical therapy for a short period of time, and education in a home exercise program that the patient can then continue to do to maintain their strength, flexibility, and do the exercises within their pain tolerance. And then the other medications that I talked about, the anti-seizure medications like gabapentin, antidepressants like duloxetine, those are other measures that can help with additional pain relief, hence reducing the need for a higher dose of opioids. Now, the other thing that we have, there's two different kinds of opioids. You have the long-acting and the short-acting opioids. The short-acting opioids are things like oxycodone or hydrocodone that get into your system pretty quickly, will last for about 6 to 8 hours, and the effect wears off after that. Those are very useful for an acute injury. Like I mentioned, the ankle sprain or a fracture. You can have a short-acting opioid for a few days or a week or two, and that may get you over the hump of the pain symptoms, and you don't need to be on the opioids beyond that time. Now, if you have a chronic pain situation, then the short-acting opioids get to be somewhat problematic, because no matter what short-acting opioid you use, there is going to be some degree of a psychological dependence on the medication. The medication, as it gets into your system, will give you a little bit of a feeling of feeling better, and those are the medications that are often more open to abuse, because the need for that continues to increase, and the patient will say, well, they have a hard time distinguishing whether the feeling good is the same as the pain relief. And it's hard to determine whether the patient is asking for more medication or taking more medication because it just feels better, or whether it's actually for pain. So in chronic pain, I personally prefer to use a long-acting medication. So the patient is on a time schedule. It'll be a medication that they will take twice a day at 8 in the morning, at 8 in the evening. They have no room to take an extra pill in the middle of the day, because the medication is supposed to have a steady level in the system and provide sustained pain relief. Those medications are also open to abuse. However, I found that if a patient has chronic pain to a degree where they need an opioid, they usually do not end up abusing this. There are, on the street, the long-acting opioids, just because they usually have more medication in them, have been more prone to abuse. And that's where you see the fentanyl patches and the OxyContin on the street being abused. But when you have it being used for a patient who has chronic pain, I have really not seen a patient abuse a long-acting medication. A very few and far in between. If a patient has chronic pain, they will stick to the rules and they will take the long-acting medication the way it's prescribed, because they know that if they do not do that, they will not be able to function in the activities of daily living. The buprenorphine patch for the first patient I mentioned is also a long-acting patch. And the second patient is on a long-acting morphine preparation of 100 milligram every 12 hours, which he takes, like I said, 8 in the morning, 8 in the evening. So he has a steady level of morphine in his system. Pretty much if anyone of you has had surgery and you're on what's called a PCA pump, it's a pump in which there's a steady drip of morphine that gives you pain relief after surgery. It's trying to replicate the same situation, but as an outpatient level.
Excuse me, Dr. Singh.
Yes.
Someone is asking, how do patients adjust to knowing that pain will be ongoing in their life? Adjust to knowing that they might not return to work.
It is disappointing, but a lot of it ends up, like I said before, it would be great to have counselors and psychologists to help with that. But at this point, it falls on the physician. And over the years, empathy with the patient is the most important thing. You have to make sure that the patient understands that they're in pain, because you often will get this thing. Well, you don't know how I feel. Your back wasn't fractured, mine was. But the truth is, I have seen hundreds and thousands of patients with similar situations, and I have worked with them over the years. And there are things that have helped the majority of them. And that's what you explain to the patient, that you cannot get it to be a normal life, but we're going to try and get you back to at least a level where you can feel happy that you're able to do some things, enjoy things around the house, your yard, your grandkids. So there is an element of counseling that has to come into it, which I try and do myself, because as I said, we don't have access to psychologists to do it. So a lot of it is discussion and getting a good physician-patient relationship going. Again, as part of the treatment, is monitoring for side effects. I think I talked about this before, the constipation and everything else, and you manage those issues. Sometimes they get to be so significant that you have to back off on the medication. And then that's another thing where the pain relief is not going to be optimal, but at least the patient has less side effects. Compliance is similar to what I talked about before, the pill counts, urine toxicology, and making sure that it's being taken as prescribed. Now, this is the bane of my existence, because some of my patients have been on chronic pain management for 10 years, 15 years, a long time, been on pain management protocols for years, have been stable, have not demonstrated any aberrant behavior, no abuse, nothing. They are living their lives the best they can. However, with workers' compensation, you can have a case change in the case manager, and immediately denials start coming up because the previous case manager understood the situation. A new case manager, either they have to show their employer that they're doing more. Had a patient just this week where the medication has been approved on an annual basis for this patient ever since the portal was set up. So for the last 2 years, January 2021, January 22, medication was approved. January 2023, we have a new case manager and the medication is denied. And a peer review is done by a physician who is licensed in all 50 states of the country. Now, there's no reason for a physician to be licensed in all 50 states of the country unless they're a professional peer reviewer that is essentially working for insurance companies. That itself is a red flag. The cost of being licensed in 50 states is probably about $15,000 to $20,000 a year. That physician wants to get paid. What's he going to do? He's going to bring out anything he can do to support the insurance carrier's denial. Fortunately, in this particular case, I presented all that evidence to the level 3 appeal to the board, medical director's office, and within a day, the medication was approved again for the whole year. My point here is, if anyone has any say with how the board is being run now, there has to be some penalty for the carriers when they do these frivolous denials, whether it's for medication or other treatments. There is no repercussion to the case manager or the peer reviewer or the carrier. Nothing, no penalty at all. The burden is on the prescribing physician to do all the paperwork, argue with the board to try and get things approved. And it will get approved eventually because we're not asking for anything unreasonable. But there is no repercussion to the carrier or to the peer reviewers who have given all that erroneous documentation to the board. I think that's something the medical director's office and the board needs to look at. It is becoming a significant problem. And that is why you're seeing physicians across the state refusing to take workers' compensation, because the documentation and pre-authorization requirements have become so burdensome that it's a constant struggle and for established patients. How can you say that they covered the medication for the last 15 years, but today they say, well, actually, no, the patient, this is not a reasonable medication for the patient. You need to wean them off. You need to do something else or start doing injections on this patient. you can't say that to a patient 15 years down the road who has been living their life with a certain medication protocol, that now you're going to change everything. And again, as I said before, you stop the medication, you're going through physical withdrawal, and there are no resources for us to help those patients either. Essentially,
Singh?
comes back to dollars and cents, but I think my time is up. So if anyone else has any questions or thoughts.
There's one question. What sort of credentials do case managers have to evaluate medical information provided?
I usually see that they are nurses, RNs. That's the most common credential that I see. And a lot of the way pre-approvals are done now is probably a computer algorithm. They put in a few things. The guidelines are incorporated into the algorithm, and it pretty much spits out reasons for denials, and that's what they're denied on. And then it goes to a physician who, unfortunately, oftentimes is a physician who is essentially has a career of doing peer reviews, and the income is dependent on the carriers giving them more cases, which is dependent on them providing more denials, because then the carrier says this physician is a good one for us to send stuff to because we can save money. So despite the board's policies of being there for the injured worker and the guidelines being written for the benefit of the worker, the insurance carriers and the case managers and the peer reviewers have pretty much twisted all of that around to serve their own purposes. They will find one line somewhere in the guideline that justifies their something, and they will use that, and it'll take weeks of trying to fight to get it back. So sorry if I sound frustrated, but it is extremely frustrating.
Thank you, Dr. Singh. Carl, you ready?
Yes, I am. So I'll just briefly introduce myself while Ronnie brings up my slides. I'm Carl Shallowhorn. I'm the Director of Youth Programs at Mental Health Advocates West New York. And my program is basically on opioids in the workforce, and as far as some things to be aware of, some strategies to acknowledge, and things you can understand with how to address some of the concerns you might have. So I basically just want to kind of mention a couple things first, and I wanted to point to a couple of comments I want to make based on Dr. Singh's presentation, which was excellent. Myself, I just had back surgery on December 14th. It was not work related, but I had a back surgery and had to go through the process of pain medication for, I'd say, over a week. It was invasive. It had to do with part of my vertebrae breaking off and touching the nerve of my foot and all that stuff. But the bottom line is it was very painful, and I had to kind of wean myself off of the medication. It's not the kind of thing where I need medication long term, but it was still a matter of understanding how to manage the pain while regaining some functionality. Unfortunately, I've been able to do that. I think the bottom line is understanding, and actually I wanted to mention too, Dr. Singh talked about not having the ability to connect with, say, professionals on the mental health side of things that can help. So what I would say though is that actually you just gave me a thought, Dr. Singh, about maybe a type of chronic pain support group with a focus on the mental health aspect, because that's a lot of what we're talking about here. How do you manage your mental health? So let me just go into things then while we're here. So I'll just kind of start off and say that basically, I just some basic statistics. So you see here, work injuries, a lot of them result from unintentional overdose in terms of just the number, 388. So that's about roughly a little less than 10%, but still, that's still a lot when you consider the number of fatalities, people dying. There's also loss of work-life balance, because you talk about the idea of work-life balance. as far as how your work life can bleed into, so to speak, your personal life. But then again, the substance use will take over and it'll affect work. So there might be people who might either come to work under the influence or be using a substance while at work. And then, of course, other statistics there. The one at the bottom that's really is most notable is untreated substance disorders cost employers $8,255 per worker each year. That's a lot of money when you consider the overall cost of substance use in general. We're not talking specifically about opioids, but in general, substance use in the workplace. So for employers, it's a bottom line issue as well. It is, more importantly, of course, the health and welfare of the employees, but it's also dollars and cents. So I want to talk briefly about co-occurring disorders. And co-occurring disorders are essentially when a person has a chronic condition that exists and needs treatment at the same time. Usually in the instance of behavioral health, we talk about a mental health and a substance use disorder at the same time. So for instance, you see here, opioid use disorder and major depressive disorder, or it could be opioid use disorder and an anxiety disorder. So usually for many people that deal with, say, a substance use disorder, they may also have a co-occurring mental health disorder and vice versa. But mostly you find people who abuse substances along the line somewhere, there may be a co-occurring mental health condition that may arise as a result of having that substance use disorder. And as you see here, they're more likely to have an income less than 100% of adults. So really, we talk about these co-occurring disorders. Generally speaking, it tends to be under lower strata of those socioeconomically. And then about 8.9 million people in our country have co-occurring disorders. So you figure 300 million people live in this country roughly. So that makes it under 1%, but still that's a lot of people that have co-occurring disorders, many of which, as you know, as you see here, are untreated. So that's the key. So of a lot of people not receiving treatment, 55.8%, that's a lot of people who are basically trying to go work, trying to do things that might be impacted by these conditions that keep them from doing what they need to do. And the bottom line here is that this affects work, this affects performance, it affects personal lives, it affects every part of a person's life if you're dealing with these conditions, because whether it be getting to work on time, performing the job as needed or as required, and then also in the personal life, we know that, as we say, these co-occurring disorders also affect a person's home life or relationship with family or friends. Those can be impacted as well. And when that happens, then many times we know there's a need to address the issue, but with 55.8% of people receiving no treatment, that means that these people aren't addressing the issue and it tends to get worse over time. One thing also to consider is that when these issues aren't addressed, they will get worse. We don't know how people will be able to just stop. Sometimes they do, substances, but it's really difficult, especially when you talk about strong drugs like opioids. It's very hard to stop once you have entered that cycle of addiction, as far as needing that substance and rely on it. So it's hard to stop on your own. So women are more at risk of depression, anxiety, and substance use and history of trauma. So these are things that are more particular, that we call them risk factors. And a risk factor is something that might be making a person more prone to an addiction disorder. So women having the risk factors of anxiety, depression, substance use, and trauma, they all kind of go together and make them more at risk for potentially being addicted to a substance such as an opioid. Additionally, we talk about the idea of opioid use disorders. Also, the co-occurring disorders, 26.4% had alcohol use disorder, 10.6% had methamphetamine use disorder, and then 64.3% of people who have co-occurring disorders had a mental illness in any given year. That's a lot of people who have both mental health and addiction going on together. And then when you talk about serious mental illness in the past year, it's almost 1 out of 3 people, maybe 1 out of 4 rather. And we talk about serious mental illness, things like bipolar disorder, even schizophrenia, major depressive disorder, and so forth. And this is across, all populations, not just the workforce, but still just kind of gives you an idea of the numbers that are affected in the country that oftentimes aren't recognized when you think about these things. So when a person has an undiagnosed mental health condition, it increases the use of a substance. So for instance, opioid use disorders, if a person has an undiagnosed mental health condition, whether it be anxiety, for instance, that's a good example, they may be more inclined to use a substance to self-medicate. And that's the term we use a lot, is self-medicate. The drug use may bring about symptoms of mental illness. So if a person is really abusing, say, an opioid, then they're more likely to develop, say, depression when they are unable to obtain the substance, or they're trying to recover or stop. Anxiety certainly can be a condition that's prompted and promoted through the use of opioids. And then we have genetic vulnerability. Essentially what that means is that if a person has in their family history, say, a co-occurring disorder, opioid disorder, mental health disorder, there may be more of a risk for developing one of these conditions because of just the DNA connection, how these conditions can be passed along from generation to generation, maybe not even from parent, maybe it could be a grandparent or it could be another relative, but our DNA is intrinsically connected to those who came before us. So if there was something going on then with a person who was, say, a parent, it could be possibly passed along to the child, and then we know that happens too. All environmental triggers, certainly emotional abuse, stress, and trauma. Trauma is a big one. I was actually just talking to someone a little while ago in my office about trauma. Early childhood trauma is something that affects a lot of people that we don't realize, or many people don't realize, will manifest later in life. So you might say, well, where do these things come from? Why does a person use substances? Why does a person have a mental illness? If you look at people's early lives, it might be something that happened in early childhood that might, say, we call them adverse childhood experiences. It's a trauma that manifests later, physically, mentally, emotionally, and it could be resulting in substance use because there's something, even at a subconscious level, traumas are sometimes subconscious because they've happened so long ago that it may not be fully remembered, or it may not be fully realized because of the pain involved with the trauma. So when we bury those things, they still can manifest in ways that we don't always recognize. What happens then is that people will self-medicate because of the things like anxiety, depression that might be resulting from them, the traumas, or even physical issues. We know that heart disease or even diabetes or cancer have sometimes been tied into this idea of early childhood traumas that over time can result. And then certainly people diagnosed with mental health conditions are more likely to get opioid prescriptions. When you think about the idea of just simply needing drugs for, say, a physical condition, also tying in with opioids, that's been shown as well. And then, as I said, self-medicating for things like ADHD, anxiety disorders, and mood disorders. Mood disorders are conditions like major depressive disorder, bipolar disorder, and so forth. Even postpartum is a type of mood disorder. So anything that affects the mood or the way that someone feels emotionally is a mood disorder. And when someone is feeling this way, they self-medicate. They want to feel better and will use an opioid because, as you heard, it's sometimes easier to access, whether it be through a prescription or even on the street. But they will self-medicate as opposed to going through the channels of, say, seeing a doctor even for the problem. Another colleague, at work today was saying how their father was, abused opioids and would get these prescriptions and basically, try to justify it by giving them away as well. When he received them, he would send them to my colleague while she was in college. And basically, people will also justify their use in all kinds of ways to make it seem like it's okay to be doing what they're doing. That's another, you could almost call it symptom of substance use disorders, is that people will try to justify the use and rationalize the use. Now, depression itself, opioid use can lead to extreme mood swings. and crashes when the drug wears off. If you have ever seen someone who is has used opioids and say is coming off, they can not only experience physical withdrawal, but also this idea of depression. And interesting enough, that's why people oftentimes keep using opioids or even things like heroin, which can be a result of pills, as that they don't want that withdrawal. They don't want that feeling, so they'll keep using. And as many as 41% of people with an opioid use disorder also have a mood disorder. So you see these numbers here kind of, the reason I throw in all these numbers is to kind of show how much the mental health and an opioid use disorder are tied in with each other. And that's critical. So when you think about it, that's something else to consider. And then with anxiety, 40% in studies of people being treated for opioid use disorders have anxiety. And then 1 in 3 people with an opioid use disorder also experience either insomnia or anxiety. So when you think about opioid use disorders, it tends to sedate, so to speak, a person, make them tired, so to speak. So when they are also dealing with it, it could also create insomnia, which is sort of counterintuitive, but the anxiety that often comes with the idea of realizing I need to get more, it becomes more present in a person's mind, and they realize that they have to seek out and find more of the drug to enable them to not have to have that withdrawal, like I said before, which can be very difficult and painful to experience. Obsessive compulsive disorder is something that ties into the idea of ritualistic behaviors. So there might be, say, things like counting, checking, cleaning, and so forth. And of course, people always make jokes, say, oh, they're just OCD, they're a clean freak. Well, there comes a point when obsessive compulsive disorder can actually get in the way of a person's daily activities. So if a person's obsession and compulsion, the disorder affects, say, getting to work on time or completing a daily task, that's when we know there's a problem. So these risk factors for these things do overlap. And then, as I said, genetics, brain functioning, trauma, environmental factors are all things that play into a person developing an obsessive compulsive disorder that has a co-occurring opioid use disorder. And then when you think about things like personality disorders, now, not to get too deep into the weeds, but in the world of behavioral health and mental health, there's some conditions we look at differently. So personality disorders are those which are harder, really difficult to treat, maybe with medications. But we think about things like antisocial personality disorder, borderline personality disorder. Those are more treated with, say, behavioral, therapies and modalities, whether it be through dialectical behavioral therapy, which is a big one for people with borderline personality disorder, and other type of cognitive behavioral therapies, more talk therapies is what I'm saying. So we know that these happen for people. 34.8% to 73% of people being treated for addiction also have a personality disorder. So as you see here, the numbers, as I said before, are very much high in terms of just the co-occurring part, having both those conditions together. So I think you can see a theme here when you talk about a person that has, say, a mental health condition and opioid use disorder. They do go hand in hand. They do, they feed off each other, so it becomes almost like a vicious cycle where you get caught up in the mental health condition and you're trying to self-medicate, which then feeds into the mental health condition and which then creates the need to use more of the substance. So it just keeps perpetuating more and more and more. And eventually a person finds it difficult to break out of that cycle. And as you saw before, the number of people, 54.8% of our country may be stuck in that cycle of not being able to break out. And that's a serious problem. So the personality disorder is a primary condition, substance disorder develops as a result. So as we see here, that personality disorder, yeah, that's the first thing that say manifests in a person's life, but substance disorder is the way that a person tries to manage it, self-medicate, deal with it, so they don't experience, for instance, the symptoms associated with that personality disorder. Now, bipolar disorder, approximately 56% of people with bipolar disorder also have a substance use disorder, once again, co-occurring. In full self-disclosure, I live with bipolar disorder. I had my first episode when I was a college student at the age of 18. I've been in long-term recovery for 35 years through a 12-step program. But I too myself know that from my past experience that having, say, bipolar disorder, I used to use substances to self-medicate, and many people do that, as you see here. The mood swings that are experienced can be very difficult and are really exacerbated, made worse by substances. And also, so you say a person is using opioids and they have bipolar disorder, those mood swings, especially the depression, can really just plummet a person deep, deep, deep into that depression. As well as, the highs that are experienced, more likely the depressions are going to be experienced when you talk about bipolar disorder and opioids. Now, treatment itself, when it comes to core disorders, we're talking about improve the quality of life. And the bottom line is what you want to do is, any person receiving behavioral health treatment for a mental health condition, a substance use condition, or as you know, a co-occurring disorder, which we're talking about, you really want to improve their quality of life, decrease the number of hospitalizations. So for people that might be maybe more on the severe end of things, whether it be with substances, whether it be rehabs, or it might be having a mental health condition, you want to decrease that hospitalization. You want to increase the stability in the person's life. Stability is huge. Having a routine is important. Knowing how to work and be on time and develop this sense that perhaps life is kind of mellowing out. It's not that roller coaster that the person was once on. Less potential for medication interactions. The thing that we know also, and of course, hopefully is understood by those watching, is that when you stop using substances, the idea of using medication and having those negative interactions with other medications is significantly, obviously, lessened, because there's not that potential for risk. And with a lot of things, with say prescribed medications, when you combine them with illicit drugs, that's a bad combination right there, because oftentimes the illicit substance, there's no real knowing of say what's in it, or even for things that may be prescribed. If a person's using prescribed opioids or an opioid medication, but using with say a mental health medication, whether it be something for anxiety or depression, that also could provide a really negative interaction. Improve psychiatric functioning, that kind of goes without saying. The person's going to do better mentally and emotionally. Higher rate of successful treatment, and then reduce substance use. So those are some of the goals and outcomes that can result with treatment. And now, core disorder treatment is really more common recently in terms, we call it like integrated treatment. When you think about the idea of substances and mental health treatment being under the same umbrella, the same provider even. Whereas years ago, they were treated in two different offices or clinicians for that matter. You might have a substance use condition here, clinician rather, and then you might have a mental health clinician, and even if they work in the same agency. But now there are many agencies that have this idea of integrated treatment, that you have a professional who can treat that person with both conditions, and they're skilled and able to do that. So when you think about prevention in the workplace, one of the things you want to do is, like we're doing right here, is training and helping leaders and supervisors to understand ways to reduce stress. Now, one thing that I haven't touched on much here is the idea of stress and stress in the workplace. I'll be honest, no matter where you go, no matter what you do for your job, chances are there's going to be stress at one time or another. A deadline, it might be something that a project that is just challenging. It might be physically stressful. It might be just things outside of work that even can cause stress that you bring into work. So finding ways that are proactive to help alleviate stress for staff. So that's one key thing. Challenging but realistic goals. Of course, if you work in an organization and you set a goal for an employee that's unreasonable, then that undoubtedly is going to create stress for that employee, and they're going to be probably more likely to feel that it's unattainable, and it'll affect them mentally, emotionally, and then thereby could potentially be a risk factor for using a substance because they can't deal with it. They don't know how to deal with it. Communicating clearly and managing conflicts respectfully, which could also be challenging because we're not all necessarily the touchy-feely types. Not that you have to be, but understanding how to have some empathy as a leader. Also, understand how to communicate clearly. So often these days, in at least some workplaces, messages are sent by email or other types of written communication. Sometimes we just need to talk to people and remember the importance of that verbal communication, and not only the verbal but nonverbal communication. Sometimes you might be saying something, but your verbal, nonverbal, facial expressions might be saying something else. So communicating clearly, and you see here, managing conflicts respectfully are so important in the workplace to prevent problems from arising. And then another thing that we like to do, and I like to do myself, is identify strengths. For my staff that I work with, I have 8 staff right now that work under me. They're all young people between the ages of 18 and 26. And I'll just say honestly, that poses its own challenge right there. They all have their own mental health challenges. So I deal with my staff that are facing things on a regular basis that requires me to communicate clearly, like the point before, but also acknowledge their strengths and acknowledge what they do well, to give them the idea that they're doing a good job. And not that you have to praise them for everything that they do, but really when you recognize an employee for what they're doing well and acknowledging the strengths, they're going to feel better about their work and more likely to want to feel that they're contributing and do a better job. And then lastly, of course, compensating fairly, which in some workplaces is difficult to do. Even where I work, my work for my employees is very challenging. We're a nonprofit. I know many people on the call may not be, we're in different types of the workplace. It'll be county systems or hospital systems. So there's just the idea of compensation where if a person feels they're not being compensated fairly, that's going to cause them additional stress. So the idea of trying to compensate people fairly is really important. And it may not always be an annual salary. It could be like a semi-annual bonus or a Christmas bonus or extended time off. There's all kinds of ways to compensate a person to help them relieve some of that stress they might be experiencing. But the bottom line here, another bottom line, is the pocketbook. Of course, it's all nice to tell a person they're doing a great job, but then again, they have to pay the bills. I'll say this last thing. One thing that a big focus has been on in the world that I live in is workforce development, in terms of just paying people and retaining employees and being able to keep them because of the idea of compensation. So compensation is really critical these days for staff. Safe work conditions is huge. I can't say enough about keeping the workplace safe, being able to keep a place that is free of accidents. Modeling work-life balance is important for managers, and that can be tough because in some jobs it isn't just a 9-to-5 kind of thing. But modeling what it means to take that time off for yourself, take that time, that PTO day, or even that day that you need to just make it a mental health day. We used to joke about that, a mental health day, but it's more real now, where people simply cannot make it because they're not feeling well mentally or emotionally. That's okay. We need to acknowledge that and give them that, especially if it's their time. If it's their time to take off, it's their time. Building opportunities to formally recognize individual and team goal achievement. I try to do that every day with my staff when I meet with them and I work with them at our staff meetings. You want to, like I said, give them a little bit of praise, which is always nice, but also recognize what the team does as a whole, because in the end, it is all for one and one for all. And when you have the whole team recognize what they're doing, then it leaves little room for the big I's and little U's, as they say. You want people to feel like they're not being singled out as one person being better than the other. I'm really big about that with my staff. I try to keep people on the same level playing field as far as how they're recognized. In other words, they all get praised, but entirely the team really gets more praise than anything. And then the idea of social support and connectedness, this is so critical to foster this climate in the workplace. Social support is really important. We spend so much time at work. Sometimes actually we spend more time at work than many times we do with our families. So you have to encourage the employees to have this social support and connectedness because they may not have it elsewhere. Some employees don't have family to go home to, don't have people in their lives to work, to be close to. It may be their colleagues to work they're closer with. So if you really encourage that and foster that, it's going to just create a better place to work at for your staff. And then developing ways to reflect on positive daily workplace events and accomplishments. These are little things. It might be a day of recognition for staff. It might be a day to do a special lunch, or anything that kind of recognizes the work that's being done. Maybe even just something like a surprise. Every once in a while, it maybe not be the best way of dealing with things, but I'll bring in a cake for my team, and we'll just kind of have something like that to enjoy ourselves. But donuts, some people bring in donuts, little things. I know may not sound like much, but sometimes little things like that. Of course, you don't always want to rely on things like treats like that. But then again, sometimes people appreciate that in a little way. Not that you do it every day, but every once in a while, it really can't hurt. Now, in terms of early identification and intervention, these are things that are really important. Screenings and information on stress reduction and early warning signs of mental health conditions. If you go to the website of the Mental Health Advocates of Western New York, it's mhawny.org. We have an online anonymous screening tool for mental health conditions. So you go on there, it's a screening tool, it's anonymous, no one's going to know that you've taken it. That's a really great place to send employees or even yourself. Ineffective intervention programs. You see here, cognitive behavioral therapy. I mentioned that before. So cognitive behavioral therapy is centered around the idea of changing a person's thoughts by addressing, say, behaviors and so forth. So they kind of go hand in hand, but if you change the way a person thinks, they're going to change the way they feel and behave. Programs effectively address stress, mindfulness, relaxation, yoga, things like that, that might be internal, that might help staff to feel better about themselves. Even if it's just encouraging staff to take a brief mindfulness break, to do some deep breathing exercises. That can be real helpful. I teach a program and I talk about the idea of a 2-minute stress buster, where you just basically do some deep breathing and it can really help. So that's something too. And then programs that improve resiliency is more along the lines of just finding things that build the mental and emotional strength of the workforce that will help them to manage the stressing better. Are there questions coming through, I think?
Yes. They wanted you to repeat the mental health screen.
Yes.
I guess they're talking about the web address.
Sure. Okay, the web address is mhawny.org. So if you look down at the bottom corner of the slides, mhawny.org, and it'll be on the last slide as well. So if you go to that website, you'll find the anonymous mental health screening that you can take. It's a great resource. Now, mind you, let me just reinforce, it's a screening tool. Doesn't mean that you have the condition, but if you go to it, you look at one of these conditions, you can check on a lot of things. It might just mean that you might want to go and get a follow-up with a behavioral health provider. And that's what, and if you need that information, you can always call us to find out where to go and how to get that help. So assessing effective care and supports, EAP is a huge one. I know that governmental agencies have EAP, great place to go. Also, you might have someone on disability. It's good to reach out to staff that are on disability to let them know that, hey, we're still thinking of you. It's okay. We're here. And even for colleagues, for that matter, if you have a colleague that's out, just check in on them. They might appreciate that. Remaining engaged with supervisors and coworkers during these times that might be difficult. Transition and return to work policy. So if a person does have to go out, say for a surgery, what's going to be like when they come back to work? What are the policies that you have? And then, of course, the ADA accommodations are the American with Disabilities Act. You might have someone that might need an accommodation of one kind or another that is legally their right to have to stay on the job so they can do their job well. So these are all considerations rather, in terms of intensive individual supports. And then, so for leadership, we talked about the idea of open communication. In other words, there should be this idea that anybody can talk to leadership, say without fear of I'm trying to remember the word I'm trying to use here. Getting in trouble, so to speak, or at least being able to come to a person with concerns without being reprimanded. That's right, what I'm trying to think of, reprimanded. Being able to just talk and let them know how you're doing. Check in and respond accordingly. It's important for leaders to do that with their staff. I mean, certainly some places are bigger than others. But if you have that ability, check in. Evaluate stress, burnout, and mental health in annual surveys. It's always good to do a survey of staff to find out, okay, how are they doing? And overall, is there anything that we need to be addressing that we're not? And then, as we said here, a mental health employee resource group. There are so many resources available right now online through our organization and others that it's actually not too hard to develop a resource tool for employees that they can go to if they need help with any of these things. I know some organizations actually have more formal, say, mental health groups or committees for this kind of thing. And it can make a big difference when you realize that you have the support and I can go to these folks and use this as a resource if I need it. It's going to make the organization stronger in the long run. So, and then, like you see here, check in and provide guidance, evaluate and assist with workload management. Workload management is another big one too. I talked about the idea of stress in the workplace. Some people, we can only manage so much in terms of our workload. There comes a breaking point for everybody. And when you talk about stress, that's why people get stressed out of work. Sometimes they get so much put on them and they're afraid to say no. They're afraid to say, I can't do it, because they're afraid that if they say that, they will, like I said, be reprimanded or be told you have to do it. So they'll just be quiet and try to do it, but they have all the stress of the workload. I know sometimes it's hard to work around a workload, especially with not as much staff that we have had recently with certain workplaces, but just trying to find ways to be creative with spreading the work out. Realistic expectations, open door and flexible policies. That open door idea is where a staff person can come to their manager, talk to them about things and leave that availability open to them. And then burnout, understand what the signs of burnout. In other words, if a person's just looking kind of dragged down, or if they're being quiet, or if they're even irritable, there's signs for burnout that you can look for an employee to be aware of, so that if they're showing these signs, then maybe, just maybe, they might need a break and might need to take some time for themselves. Manager training is always very good to learn about mental health tools and ways to be healthy and practice those things with staff. Shared decision making is good, because this is a case where, and I do this sometimes with my staff, whether it be individually or with teams, where we decide together, okay, what might be a good practice, a good thing to do, either for our department or for the agency. So when you provide that shared decision making, you allow them to buy into what's happening in terms of the process. And the mentorship's really good, because you're getting a seasoned staff member to work with one staff member who may be new or younger in the organization, to teach them maybe ways that can help to onboard even faster than they already are. And then for employees, you can also include mental health and orientation. So this is another thing too that's important, as far as incorporating a mental health segment in orientation, to help them understand what are some things we value in our organization about mental health. The importance of taking that day if you need it, or being able to go to EAP, or come to your supervisor if you're struggling. Major awareness campaigns. May is Mental Health Awareness Month. So remember, May is the month to maybe do something special for employees' mental health, or recognize that it's that month. Like I mentioned before, establish a mental health team, train managers regularly, and senior leadership also, as I said before, can model open communication. Another question? So I've offered some resources here. Like I said, this is my agency, mhawny.org. So you can go, we have a lot of resources on the website that you can go to. You can find information on. There's things on, the screening. We have information on local support groups. We have a number of support groups through our agency. We have information for families. We have information for youth. We have information on, even children in the military. We have a children in the military program. So a lot of great things we do that many people don't even know about us. So check out our website for sure. National Safety Council is a great resource also for getting information on mental health and substance use conditions in the workplace. Center for Disease Control, the New York State Office of Addiction Support and Services, OASAS. They have a lot of great resources. Workplace Mental Health, and then Mental Health America is another great resource. It is the parent organization, the national organization of our affiliate. So Mental Health America is mhanational.org, and Mental Health America has a lot of valuable information on their website and links to other resources. But what it comes down to, though, is there's so much information available online that people can access to learn how to better take care of themselves mentally and emotionally. We're in a world of, we're still COVID. I don't care what anybody says. People are still getting COVID. We're still dealing with stress every day, more and more, it seems like. So it's so important to take care of ourselves because we oftentimes carry these things into work with us. And going back to the topic of our forum, opioid use, it's just so critical to understand that when a person is dealing with things that are affecting them mentally, emotionally, if opioids get brought into the picture, it's just going to make working that much harder. And understanding, like I said before, if a person has a surgery or any reason for needing to take an opioid-based medication, to manage it properly, to take it as directed, and to try to limit, if at all possible, the use. And if it is over the long term, understand the more importance why it must be taken as directed and as prescribed by a doctor.
Carl,
So, yeah, yes.
the question is, what would a mental health employee resource group look like with the challenge of employees' concerns on confidentiality?
So I'm going to come out actually of this. So I would say I've seen other organizations where they have a committee, and usually it's formed of people who are, say, leaders, if you want to call it that, or they might be managers or employees that are kind of setting a tone. Now, the thing to recognize too is that you're kind of creating a workplace culture. You're trying to create a culture around good mental health. So if you have formed, say a few people in a organization say we want to start a mental health committee, you could start it and create policies around, say, confidentiality. That if anyone has an issue, that you'll state out right out in front. If someone comes to us, it's confidential. Now, the thing about confidentiality is, of course, if a person's at risk of hurting themselves or somebody else, then that needs to be reported. But these things can be stated explicitly. There are even places you can go, I'm sure online, to find out information on how to develop a committee in the workplace like this that you might be interested in. And then, because it's like going to the counselor or the psychologist. No one wants to walk into a behavioral health clinic and see them go in there because there's so much stigma around mental health. And that's another thing too. There's so much stigma, but we have to erase that stigma. We have to let people know it's okay to ask for help. It's okay to talk about it. And when we start doing that, then maybe people will be less likely to feel, say, self-conscious when they realize either themselves or someone we know has all been affected this way. Everybody has been affected, themselves or someone they know. So we need to get rid of this idea that I'm the only one. We've all been affected. Any other questions?
Nope.
Well, if not, I guess we're almost at noon, I think. So I think we're supposed to close at noon, I believe. I don't know if you had any other comments you want to make, the other speakers or panelists, or
No other speakers or panelists. We hope everybody would check back in and attend the in-person Narcan training that's coming up. But that's it.
well, thank you for letting me be here.
Well, thank you. It's I've enjoyed all the presentations, and I want to encourage those in Buffalo to build on today's presentation and think of how we can do a more comprehensive job of addressing these issues. Because I think what Carl and Dr. Singh have talked about shows the real gaps in the healthcare system for dealing with these things.
Thank you very much to the organizers for at least giving this forum to speak my mind. Hopefully it didn't go too far.
Well, I
Thank you all
appreciate
for participating, and thank you to everyone that joined us on our call today.
it. Thank you.
Thank you.